issues. So before we start, I would like all of you to identify these classifications very clearly. One is a vascular tumor. Please do not use them interchangeably. These vascular tumors are the one which are called as infantile hemangioma. These are all clonal proliferation of cells, which requires pediatricians and the specialists in management of hemangiomas. They have got a role in vascular tumors. And on the other hand, you have another set of red-looking issues which are called as vascular malformations. They are structural anomaly. They are all nothing but low-flow vascular anomalies, which no drug can do anything for this vascular malformation. It has to be done by a pulse dilator. So there are two things which has to be aware of. One is vascular tumor, where we can do drugs, we can make use of drugs, we can use lasers, we can use pulse dye and beta blocker concurrently for a faster efficacy, but in vascular malformation, drugs cannot have any effect. These are the vascular malformation different types. I'll be making my talk as interesting and most importantly as quickly as possible, so that we will not waste time. You have a lot of other things coming up, because this is only the miniature of a pediatrician's practice. So let's find out how infantile hemangioma look like. This is a commonest tumors in infant and children. So it is worthy of an attention to know about these tumors in detail. This is, you see, IH more common in infants, more commonly in female infants. And interestingly, the complications are also equally seen more in female infants. The pathogenesis is a clonal proliferation. It has got a proliferative phase. It has got an involution phase. We all know that. And how long we should wait, when should we intervene, we will find out soon. The clinical features are very simple. These are the different types of hemangioma. You can see superficial one, which you see in clinical practice. Some of them can be a deep hemangioma. On the extreme of the right, the pictures are not very clear because of the light. It is a mixed hemangioma. The natural history is very, very important. Not all hemangioma require intervention. The hemangioma which require intervention are the one which are high-risk hemangioma. The natural history is very, very important, because the hemangioma is not seen at birth. The capillary malformation is seen at birth. If you see a red lesion on the day of birth, it is unlikely to be hemangioma. Hemangioma will occur in the first few days to few weeks of life. This is point number one. Number two is evolution. The natural history, the hemangioma grows very fast. It attains its 80% of the size by the age of 3 months. It attains at 90% of the size by the age of 1 year. So if you intend to intervene, suppose you are looking at a high-risk hemangioma, hemangiomas around the mouth, hemangiomas around the genital area, you start thinking about intervention much earlier than later, because the 4 weeks to 6 weeks is the time where it is at its maximum growth. As we know, the cells which are growing faster are expected to respond faster, isn't it? The cancer cells, they do respond when it is proliferating fast. So the newer studies have clearly shown that every second hemangioma you're seeing in your clinical practice is going to leave some residual change. It is not that the old school of thought, wait and watch, cannot be applied anymore. The IH, which can give rise to disformation or can leave redundant skin or telangiectasia, we have to take that into consideration, especially in the era of children or not many. We have 1 or 2. Even if it leaves a pigmentation, if it leaves a scar on the face, it won't look nice for a child to go to the school with a scar. So do not dispose infantile hemangioma quickly. Just spare a thought. Just give it an extra time. The least you are expected to do is to take a clinical picture and ask them to come back after a month. I'm not talking about the high-risk hemangioma. High-risk hemangioma require intervention immediately. If you see any of the hemangioma which do not require immediate attention, please take a picture and follow it up every month. And these are the IH which are prone for scarring. These are the, let me show you the pictures. You can see the hemangioma which require attention. Have a look at the hemangioma which is as big as this, or the hemangioma on the orificeal area, or hemangioma on the ocular side. You have to intervene early. These are the high-risk hemangioma. Some hemangioma can be like this. This is a box's the glove-like distribution of hemangioma. The hemangioma can be a segmental hemangioma. These are different types. And what are the complications you expect to see in hemangioma? Ulceration. Look at the different ulcerations the hemangioma can go in for. Do not wait for the ulcer to heal. Do not wait for the propranolol to take effect, because it's going to take at least a few weeks to take an effect. If you see ulceration like this, it must be treated with a laser. This is the main purpose of me coming here and meeting all of you, is to when should we intervene. This ulceration is not going to heal unless until you intervene. The ulceration is very painful. If you see a child with a ulcerated hemangioma, you will not forget the child for the rest of your life. It keeps crying, crying all day and night. The periorbital hemangioma, which can give rise to visual axis disturbances. So we all know that the ophthalmology will be of great help. Congenital hemangioma. This is one specific hemangioma which is very rare. I have not seen many CH in my clinical practice. And whatever hemangioma you see in your clinical practice will always be IH. It is not congenital hemangioma. It is a separate entity in which the hemangioma is present at birth, is a full-grown tumor. Fully grown tumor is called a CH. It looks like this. There's a fully grown hemangioma. It is not a congenital hemangioma. What we see in clinical practice is nothing but IH. The general approach is there is the variety of the things that can be done. Apart from lasers, we heavily depend upon beta blockers. And my only concern in beta blocker is a disease which is as localized as hemangioma, which is not multiple, which is not systemic. Why can't we try laser? I will show you my work on laser with IH. Though the propranolol is expected to work, it doesn't require a lot of money to prescribe for the patient to take propranolol, but the laser has got its own role. These are the lasers. I will show you just clinical pictures. This is you can see the ulcerated hemangioma healing beautifully in 4 sessions of pulse ray laser. So the point is, the ulcers do not heal unless and until you hit them with the laser. I did not use propranolol in many of the pictures what I'm going to show you. This is one good clinical clearance you can see with pulse dye. The treatment was done under general anesthesia. It's quite a painful procedure. It took about 3 sessions for the patients to show a result like this. I will show you just clinical pre and post photographs of different ulcerated hemangioma. You can see the hemangiomas. The hemangiomas which are seen on the folds of the baby, they are likely to get ulcerated. So those are, you have to watch it for those ulceration. Always use antibiotics systemically and topically, but it is not that you only rely on antibiotics. This is one hemangioma. If you see a female infants or children with hemangioma, because of the site of the hemangioma, it is likely to get ulcerated. The pain is always an issue. So you can see the clearance of hemangioma pre and post photographs. Most of the patients do not require anesthesia, except the orificial hemangioma, which is a painful procedure. So I always take help of an anesthetist who will help me with a peaceful 10 minutes time. This one hemangioma which was very bulky, I did use propranolol along with pulse dye laser. The recent report clearly said the combination of beta blocker and pulse dye will reduce the clearance of hemangioma, will ensure clearance of hemangioma in probably 50% time lesser than the regular time taken by the propranolol. So effectively we are cutting down the duration of therapy on a child which otherwise will be put on propranolol for at least 1 to 1.5 years time. Normally you use them for that longer period of time. If you combine them with pulse dye, the result is going to happen in 6 months time. This is a hemangioma. This is a look at the result of the pulse dye. This case was again referred by a tertiary institute. Nothing was done except pulse dye. I did not even use any other drug. 3 sessions could bring about clearance like this. Why don't we offer these modality to the patient rather than blindly banking only on propranolol? Propranolol is a wonderful drug, but it can have its own side effects. You all know that. It can have side effects which can be fatal. So the disease, again I'm repeating, the disease which is as localized as hemangioma, does it require a systemic drug for that long period of time, which can, the result what you can show, you can bring with laser is always much faster. Though it is, again, the only thing that is against laser is the cost and availability. For example, the pulse ray laser is available in, with me in Tamil Nadu, the only person I have in Chennai. If you take the entire country, there are only 4 machines available. So availability is always an issue, but if it is available, I think we should make use of it. You can see the good clearance. The oral hemangioma in children, I have not seen many. I've seen few of them. They can have a lot of problems like deglutition issues, infections, or they can have the painful swallowing. So you can see good clearance of the hemangioma. All these things were done without propranolol. The picture you can see here, the boy was not able to protrude the tongue comfortably. The post-treatment picture, you can see the good protrusion of tongue. Not only the protrusion, the pain came down quite significantly. Otherwise, the boy used to take antibiotics every 15 days. Adult hemangioma, because the children with the hemangioma, you can see the surgical excision attempted by the surgeon, and the excising hemangioma which is flat like this is not possible. A simple laser can clear. Again, adolescent boy with a massive keratotic hemangioma. So the efficacy of laser is such that it just melts the hemangioma. You can see I was talking about a boy with the angiokeratoma. The 4 sessions of pulse dye cleared most of his angiokeratoma lesions, and all the treatments were done with a platelet of 10,000. You can see the pre and post photographs. Now let's move on to another spectrum of vascular issues, what we call it as capillary malformation. It is a lot different from hemangioma. Hemangioma, you can argue in favor of propranolol, or in favor of a systemic steroid, or in favor of intralesional steroid, or laser. When it comes to capillary malformation, drugs have got no role to play. This is the lesion which you see on the day of birth. This is how a capillary malformation, what we call it as port vein stain. This is how a port vein stain looks like. It is a dusky, blanchable erythema on a newborn. If you see a child like this, you have to advise the treatment. Here, there is nothing like waiting. The senior dermatologist and senior pediatrician have got one thing to say to most of the red lesions: don't do anything. This is how a baby with port vein stain look like. What will happen if you don't do treatment at that age? This is what is going to happen for unfortunate people, and few of them have lost their vision. If you see a port vein stain around the eyes, always exclude glaucoma. And port vein stain is not a simple issue. It is a continuously proliferating disease. It can have a soft tissue growth. It can have a bony growth as well. So if you treat at this age, no complication can happen. The result will be a lot better. The treatment in the children with port vein stain will be again a pulse dye laser. It does not require anesthesia. What we normally do is we keep the baby, the mother, along with the mother in the treatment area, simple topical anesthetic cream, and then do the procedure. If it is very extensive, you always take the help of anesthetist. But it's very safe. Most of the vascular work on children are all daycare procedures. They do not require admission, just a simple procedure. Now I will show you the port vein stain in children and also adolescent people. You can see the pre and post photographs of various port vein stain. This boy had port vein stain, and the issue was not the redness. Here the issue was recurrent cellulitis. So you can clear all of them. A young girl like this with a port vein stain, how do you expect girl to face a society. There is a lot at stake for women with vascular issues on the face. These are all adult people. You can see the pre and post photographs. This should have been avoided. See, the treatment is being given for a girl. You can see the soft tissue growth. The Port-Weinstein in the children and newborn will not have soft tissue overgrowth. If it is allowed to exist beyond 5 years or 10 years, the girl is going to develop soft tissue hypertrophy and the lip swelling. Though we can improve the lip swelling, we can clear the Port-Weinstein even in adult. But it would be better, it would be easy for me to clear Port-Weinstein if the baby or kids come much earlier than later. Again, a thing. Telangiectasia, we do get sometimes children with telangiectasia, the red, streaky, worm-like lesions on the face. It requires pulsed laser. The venous lake, which can happen to anybody, usually you see them in children. You can see the bluish discoloration on the lip, which can be cleared very easily with pulsed dye. And before I wind up, this Capillary you are all aware of, isn't it? So this is how a Capillary look like. You can see the red, massive lesion on the thigh. I brought this slide only to impress upon the necessity to make the right diagnosis. This case was treated as hemangioma. It was not hemangioma. It was a case of Capillary syndrome. What you must make out here is a soft tissue hypertrophy. You can see the lip swelling, lip lengthening. This case was treated in a very big institute with propranolol. Capillary is a capillary malformation. Because of the size of the lesion, it was misdiagnosed. What happened after the misdiagnosis? The baby was put on propranolol and systemic steroids, not for 1 month, for 1 year. The baby started putting on weight, obviously. It became more irritable. And thankfully, it was referred to me. The diagnosis was Capillary. Propranolol has got no role to play. So this is what the information I would like to pass on to the senior colleagues, pediatricians here, is do not discard any red-looking lesions. Just to divide them into 2 categories. On one side, you're looking at vascular tumor, which is a clonal proliferation, which is a tumor. On the other hand, you're looking at a capillary malformation, which is a low-flow vascular malformation. The one on my left hand is tumor, which requires active non-intervention. You divide IH into 2 categories, high-risk categories, non-risk category. If you think the IH requires treatment, use propranolol. Or you have an option of laser, you please make use of it. On the other hand, you have a disease called Port-Weinstein, where nothing else works apart from laser. I once again thank the organizer, the chairperson, for giving me this opportunity. The moment I requested a talk to Dr. Satya, she immediately accepted my request to include me as a speaker. I once again thank the organizer. Thank you.